All right, let's talk about drugs that affect the respiratory system. So, looking at the respiratory tract, it in general is a pretty good germ fighter. And by germs, we're talking about bacteria, foreign bodies, viruses, etc. The upper respiratory tract is responsible for sneezing. It can create excessive mucus production to get things out of there. When we're looking past the nose, the laryngeal area, the trachea, or the bronchial stimulation, if any of those occur, then of course they're going to initiate a cough reflex. Also, we have this option with the larynx to simply slam shut, which is a great evolutionary protective feature when it's used appropriately. However, sometimes, of course, that can be an inappropriate reaction, a laryngeal spasm. And then the trachea and the bronchioles have sheets of beautiful mucus covered epithelium. So these nice ciliated columnar epithelial cells that are covered in mucus in these areas. And then, of course, we can't forget to talk about the cilia themselves as well, which are the little hair-like structures on the epithelial cells that help to move the debris or foreign invader out of the respiratory tract. Almost lastly, we also have multi-unit smooth muscles all around the alveoli to shut them off as well and keep intruders out. And then, of course, within the respiratory tract, we have a ton of beautiful macrophages which circulate around and, of course, phagocytize foreign invaders. Overall, the respiratory tract has a prevention of pathogen infiltration through these mechanisms. We have expulsion, which of course the reflex is coughing. We have dilution, which the body produces mucus to help dilute pathogens. And then bronchoconstriction, which is simply closure of specific areas within the respiratory tract. Normal mechanisms, these are all normal mechanisms to keep foreign invaders out of the respiratory tract. And in short term, these normal mechanisms will compensate or prevent lung disease. So if we think about compensating for infection, for atelectasis, etc. So short term, these mechanisms are great and they have good short term effects for the body. Long term though, so if these protective mechanisms are engaged long term, it can be really problematic for the animal. So non-productive coughs over time could cause vascular damage within the respiratory tract. If there's continuous bronchoconstriction, we're starting to look at things like collapsing trachea, asthma, and upper airway disease. Increased pressure in the lungs can cause right-sided heart failure or cor pulmonale, which I'll talk about here in a sec. So looking at some of these long-term consequences, these protective actions, if they're engaged for too long of a period of time, they can result in these long-term problems. So in those cases, sometimes we actually have to shut down these protective mechanisms in order to allow the body to heal properly. So looking at non-productive coughs, like I mentioned before, they can collapse areas of the trachea or they can damage the vasculature to the heart. And in those cases, we start to get this thing called cor pulmonale, I can never say that properly, but essentially it's a right-sided heart failure. So it's an enlargement of the right ventricle due to high blood pressure in the lungs, usually caused by chronic lung disease. So sometimes we'll give medications to stop these long-term protective mechanisms so that they don't cause long-term effects or permanent effects on the body. So we'll start to look at some respiratory drugs. And of course, to start that, we need to know the goal of respiratory drugs. So like I just said, sometimes we need to shut down or minimize the protective mechanisms in order to allow the body to heal. So shutting down that non-productive cough to avoid tracheal collapse. And the treatment has to be considerate of the effect it will have with respect to reducing the natural protective mechanisms as well. So when we're shutting down these protective mechanisms, we still have to think about if it's the right idea to shut them down or do we let them continue. And I'll talk about this when we talk about allowing for a productive cough to help get things out of the body, remove things from the body. So we're going to start by looking at controlling the cough. And the cough reflex is controlled by the cough center in the brain. Who knew? Seems like an obvious thing there. So essentially the cough center is a cluster of neurons next to the respiratory center in the medullary area of the brainstem. So it's that very, very basic area of the brain. And cough receptors are located in the larynx, the trachea, the bronchi, and bronchioles. When they're stimulated through irritation or otherwise, they send impulses to the brainstem, which of course creates the cough reflex, which is a contraction of respiratory muscles, and it creates that sharp, forceful expiration. So in dogs, very common to hear them cough once in a while. Of course, if anything is a continuous cough or it's specific to, after exercise, etc., then that's something to be concerned about. But coughing in dogs is pretty normal once in a while, and there's lots of different causes for coughing. Cats don't normally cough, so anytime we see a cat that's coughing, definitely that cat needs to be seen by the vet. Even if they're coughing periodically, it's not normal for cats to cough. So in those cases, it's often associated with bronchitis, but cats also get asthma as well, which is really common. So coughing cat definitely needs to go into the vet. So then we have to look at what type of cough it is. So we sort of classify coughs based on their location and the presence of mucus. Is it an inhalation of food? So I don't know if any of you guys have the dogs that just wolf back their food super quick and then cough out a whole bunch of kibbles, but that's my dog right there, I'm sure. So if it's an inhalation of food, then we're looking at the laryngeal and pharyngeal receptors that are creating the cough. And that can create constriction of the small bronchioles. And that's sort of that, after you choke and you can't seem to catch your breath, then that's that cough center reception and vasoconstriction of those bronchioles. Constriction, sorry, not vasoconstriction. And then lower in the trachea and the bronchi, we get that production of a deep cough. And with that, we can get tachypnea, we can get bronchoconstriction, bronchitis, irritating gases, allergic bronchoconstriction. All of those things can cause it, including pressure on the bronchi from an enlarged heart. So all of these things together, we've got location, the whereabouts for the cough, and then of course secondary is the presence of mucus. So looking at if it's a dry or non-productive cough versus if it's a wet or productive cough. So a dry deep cough means that it's happening lower in the trachea or the bronchi and there's no mucus coming from it. And of course any sort of wet cough has mucus production along with it, and then we would classify it depending on where it's coming from. Okay, so now we know the different types of coughs and that yes, coughing can be a really great protective mechanism, but too much coughing can cause issues on the body. So let's check out the drugs that we might use for coughing. This word antitussive is a general word given to drugs that stop the cough. So they block the cough reflex. So coughs can be classified as productive or non-productive, as we mentioned, and we'll carry on talking about that productive versus non-productive in the choice of drugs that are often used for each case. In general, we always take caution using an antitussive when the animal is unable to clear thick mucus from the respiratory tree. And typically, we don't use antitussives for productive cough. We want to let the virus work its way out. So this is where it starts to get a little bit complicated. So an animal has a cough, the owner wants it to stop. So of course, number one thing we should be doing is looking at why that animal has the cough. And I would hope that the vet does this, certainly before prescribing a medication. But secondary to that, looking at the type of cough that it is, sometimes the vet has to weigh the risks versus benefits of giving the medication compared to the risks of taking away those symptoms. So if we look at the instance where the animal has a really disgusting thick mucus that's coming from their respiratory tree, if we stop the coughing, if we completely suppress that cough reflex, then there's potential that they can actually choke on that mucus that's blocking their respiratory tree. So if it's that thick, really, disgusting, fairly dry, toothpaste-like mucus, now that you guys get a good visual picture of that, then we actually don't want to stop the cough necessarily because we need that cough mechanism to help push that mucus out of their respiratory tract. And then second point there is we don't often use antitussives for productive coughs because productive coughs most often are caused, there's always a caveat to that, but most often they're caused by viruses and bacteria. So we actually want that cough production, that cough mechanism to get that mucus, which has the virus and the bacteria, out of the lungs. So then we have to think about other things such as oxygen. So humidifiers when we have a productive cough can be really excellent, but mostly we're using humidifiers for upper respiratory illness rather than lower. In general, when we're using humidifiers, again, mostly for upper resp, we can use them for lower respiratory productive coughs as well. However, the animal tends not to take a deep enough breath to actually get those fluid droplets into their lungs. So it tends not to be as impactful for those deep productive coughs. But in general, oxygen administration is really great for any animal who's having a respiratory issue, whether it's minor or major, they need oxygen. And what we're looking at here is an oxygen bubbler, so essentially a humidifier. So oxygen itself dries the respiratory tissues out quite a bit, so it has 0% humidity. So what we do instead is we run this oxygen line through a bubbler, i.e. humidifying the oxygen that's then getting passed through the tube into the animal's nose or mouth or otherwise. If an animal has a cough and we want to get rid of a productive cough or at least support the productive cough and we don't have antitussives that are available to us, then we could potentially use a humidifier or a nebulizer or a coupage. And I think I have a video. Yeah, there's a video right here. So just a little backup. Humidifiers are overall humidifying oxygen before it enters into the body. Nebulizers can do the same thing, but we also can add medication to nebulizers, and it allows the medication to become a vapor to be inhaled by the animal. And then coupage is what we have here. And coupage is an act of physically using your force to release some of the mucus that's accumulating within the respiratory tree of the animal. So here's an @Dove video about coupage, and I'm just going to fast forward it a little bit. So I'm just going to fast forward this. So she's talking about using a nebulizer, and I'm hoping that you can hear this because I realize I'm recording with my headphones in, but I'm just going to turn the volume down either way. So what she's doing is using a nebulizer to pass oxygen that's been humidified into a vapor to the patient themselves. And then she's going to use a procedure called coupage, where she's physically exerting her own hand pressure on the patient's thorax in a cranial motion, so lateral cranial motion, to help loosen some of that mucus that has become stuck on the side of the lungs. So that is a procedure that can be really helpful for patients who are having difficulty breathing, especially if they have that productive cough. So looking at some antitussive drugs, we don't really have a lot available to us. We have centrally acting, which suppress the cough centers in the brain, and we have locally acting, which reduce local irritation. Risks and benefits of both, and we'll talk about the different types coming up in a minute here. But risks versus benefits, remember, we have to watch out for inhibiting the body's natural defense mechanisms for airways. So if we are inhibiting this and they need to get the fluid out, they need to get the mucus out, they need to get the virus out, but we're actually shutting down their cough, then we could increase the risk of some of these dangerous things such as pneumonia. Long term, if it's a non-productive cough, we know that we can get into tracheal collapse, right-sided heart failure, asthma, COPD, short-term acute lung disease. So we're just looking at the overall, what are the risks of treating it? What are the risks of not treating it? So looking at centrally acting antitussives, we are generally looking at opioids, and I'll just flip back for a quick sec. Locally acting, we don't have locally acting for animals. Locally acting for people are things like lozenges to help suppress that local reaction to the cough reflex. So looking at centrally acting antitussives, typically we're talking about opioids, and butorphanol is a common one. So it's a centrally acting opioid cough suppressant. It's, of course, classified as a class-controlled substance, so we have to most definitely record it in the controlled drug log. And it's commonly used as an analgesic or sedative, and we talked about this. Butorphanol doesn't work that well for pain, but it works really great for sedation. And in general, the key point here is all opioid drugs suppress the respiratory center and the cough center in the brain. So that being said, it then comes down to choosing the best opioid for the job. So choosing the best opioid that's going to have the most minimal side effects on the patient to allow that cough suppression. So hydrocodone or Vicodin syrup, I talked about when we learned about opioids. It's an orally administered potent, and that's it should say mu opioid receptor agonist. It's more potent than codeine, and it's synthesized from codeine. It can mask the signs of pain, which is really important for us if we're giving this to a patient who has a potentially changing condition. So if we're monitoring a patient closely and we're worried about the development of pain because of, whatever condition may be at play here, then we have to be careful because we're administering an opioid. It is a controlled substance, and of course, like most opioids, it can cause constipation, and sedation is common. So if we're looking at opioids, we're typically going to grab the hydrocodone, because it's formulated as a Vicodin syrup, so specifically for cough suppression. But if we don't have that in clinic, as many clinics don't, then butorphanol is a good secondary option. Furthermore, some clinics still use codeine, which I would say most are on their way out with codeine. It's a relatively weak mu-opioid receptor agonist antitussive. It's used in many cough formulations, more so for people than for animals. And it has side effects like hydrocodone. So we're talking about a bit of sedation and definitely some constipation. So just keeping in mind here, if an animal was given codeine at some point for cough suppression and the owner wants to continue that and they have, Tylenol 3s or otherwise, something that contains codeine in their house, we as RVTs have to be very specific to let them know that we are giving the animals pure codeine and not acetaminophen plus codeine. So of course, codeine is more of a human-based medication at this point in time, so you have to watch out for those human-based formulations. And then there's dextromethorphan, which we don't use in animals in general. It's definitely in human over-the-counter cough medication, but it's just generally not effective in our dog and cat patients. So that being said, really important because a lot of clients might want to go ahead and give the Robitussin at home because it has this nice antitussive. And if they call to ask you about it, the main reasons we don't give this one at home is, number one, it's not very effective. But number two, in a lot of these drugs, if you just look at the various medications that are in them, this one in this case, this one has phenylephrine, which is a concern, especially with cats, as my cat jumps on the table. I don't know if you guys could hear that or not, little bugger. So looking at, giving cough medications, over-the-counter cough medications to our patients, it's definitely advised against. And it's because some of the medications just aren't effective, but also they have numerous medications in a lot of these formulations, which can be really, really scary for dogs and cats. All right, moving on to mucolytic drugs. So why do we need mucolytic drugs? Well, when there's an infection or inflammation in the respiratory tract, inflammatory cells are going to migrate to the affected area to fight infection and clean up that cellular debris. So generally, when this is happening, they're breaking down the cells. So the cells, those inflammatory cells, they die and they break apart, they lyse, which means that they release their contents, and the DNA chemically reacts with the mucus. So the mucus in these cases becomes that really disgusting, thick mucus. So that's almost like paste-like mucus, which is way thicker, way more sticky. So it's really, really difficult to get that mucus out. It gets stuck to the surfaces of the respiratory tract. And the epithelial cells, their cilia, have a more difficult time moving that disgusting, thick mucus out of the respiratory tract. So this is where the mucolytic drugs might come in And the goal here is to get the bad stuff out. So the goal is now to break down or lyse that thick, disgusting mucus to allow a lower viscosity. So to allow it to be a little bit more fluid-like to help get it out of the respiratory tract. And of course, this will allow the ciliary removal. So those cells can now brush the mucus out of the respiratory tract. A drug that might be used for this specifically is acetylcysteine, also known as Mucomyst is the trade name, and it decreases the viscosity of the mucus. Most often this one is administered as nebulization because it can be an irritant to the lungs, which is kind of tricky. It's a catch-22. We're using it to support the lungs, but it can be irritating to the lungs. So typically we're looking at nebulizing it, so creating it or mixing it with oxygen to create a vapor, and the animal inhales the vapor. So this drug in particular breaks up the disulfide bonds in the DNA of cellular debris and inflammation, which of course stops it from forming that thick, dense, disgusting mucus. However, of course, as you can imagine, some animals might benefit from a mucolytic, and either the clinic doesn't have any acetylcysteine, they're concerned about using it because it is a pretty, sort of like a big time drug, or the client just wants to do this at home and help their pet while they're receiving treatment on and off at the clinic. So for this, it can be really helpful to a point if they specifically have upper respiratory thick, disgusting mucus, so upper respiratory tract infections. If they don't have a humidifier, then of course they can close the door in the bathroom, turn the shower up super, super hot, and have just happily sit there with their cat or dog, not in the shower, but in the same room to take in some of that nice, humid vapor. It's something at least. And that's the thing, right? Sometimes it's like, okay, we don't have the class A solution, so what can we do instead? What is something that we can do? Moving on, expectorant drugs. So expectorants increase the fluidity of the mucus, and they increase the amount of water to the respiratory tract. And they stimulate this through this parasympathetic nervous system. In general, expectorants aren't really used in vet medicine, well, specifically with dogs or cats. Quite often you might see guaifenesin added to an equine protocol for anesthesia to help increase the likelihood that any of the respiratory tract secretions will be fluid-like rather than sticky and thick. But for dogs and cats, we tend not to be using these often at all. So guaifenesin is one that I just talked about, also known as GG, and it's typically something that you're going to see with equine patients, only when they're undergoing anesthetic. The other version of expectorant drugs are sodium-based ones, so saline expectorants. We've got sodium citrate, ammonium chloride, potassium iodide, and those ones are sort of over the counter as well that you might come into contact with clients. Main thing here, we don't recommend them. They're not overly effective, and with the saline expectorants, we have to watch out because saline can be a massive gastric irritant, so it can cause vomiting in a lot of patients. But one way to remember it's not a way to remember, but just something thinking about expectorant drugs, if we are adding an expectorant drug, the goal here is to increase fluidity, which I hope this beautiful picture can sort of seal that into your memory of the little Niagara Falls of snot coming from this dog's nose. So that's sort of something that you'd see after the use of an expectorant where they're just, releasing copious amounts of mucus because now it's all beautiful and fluid-like. And then we have the talk about essential oils, which are really popular right now, and a lot of people like to use essential oils for everything under the sun. So this is a silly cartoon. Essential oils cure, no therapeutic evidence. So that's the reality with essential oils when it comes at least to veterinary medicine. I can't speak to human medicine. I'm not going to go there. But sometimes people will be like, I put them in a room with a shower running, and I put on a nice like tea tree essential oil diffuser and blah, blah, blah. So some people like essential oils. That's cool. I like them in my house. But we have to be really careful in using these to expect an effect for dogs and cats. So in general, they're not particularly useful. We don't have any evidence that they are supported in veterinary medicine. And in fact, they can actually be an irritant to the respiratory tract. Many of the oils can coat the respiratory cells and directly stimulate the respiratory cells to stimulate sort of an inflammatory reaction or effect. So examples here, pine and eucalyptus can have negative side effects on the respiratory tracts of animals. And then, of course, I always add it, some essential oils, of course, are in general toxic, such as tea tree oil. If we apply that to the skin of dogs and cats, it can become a paralytic agent. So just something to think about. Clients often want to use essential oils, and I understand it because they're very popular, but we can actually cause more damage than good. All right, carrying on, decongestant drugs. So these drugs reduce congestion of swollen nasal tissues by stimulating the sympathetic nervous system alpha-1 adrenergic receptors to cause vasoconstriction. So the goal here with that big, huge, wordy sentence is they're causing vasoconstriction to reduce the amount of swelling within the respiratory tract. That being said, decongestants are rarely used in veterinary medicine. And at this point, you're probably asking yourself, like, Chris, why are we learning about these stupid drugs if we don't use them very often in vet medicine? And unfortunately, that's the nature of our business. A lot of times we have to know about these drugs that we don't use, in part because one day it could change and we could start using them. That happens all the time. But really, it's because clients are going to ask you these questions. So clients are going to ask you, what over-the-counter medication can they give their dog who's coughing? And you have to come up with a solution or at least an explanation as to why we don't want to give these drugs to our pets. So it's more about the education component. So I apologize in advance. You have to learn about all these drugs that we often aren't going to use. Okay, so examples of decongestant drugs. Pseudoephedrine. It's a really effective decongestant. Again, more with people. And this is one that you'll find in like Dayquil and in a lot of those cold and flu or cold and sinus drugs because it's a decongestant. Caution. It's a methamphetamine precursor. So we all know meth is bad. Meth is a bad drug. We don't want to do meth. When it comes to pseudoephedrine and derivatives of pseudoephedrine, it is a methamphetamine precursor, so it can have some of the negative side effects as meth. In that way, we're not talking about losing your teeth and getting meth teeth. We're talking about things such as tachycardia. So stimulation of beta-1 receptors to cause tachycardia. So not great for the cardiac system. Phenylephrine, it's not as effective as a decongestant, but it is there, and quite often you'll find it in over-the-counter drugs. It's not a precursor to methamphetamine, but it also can cause the tachycardia due to stimulation of beta-1 receptors. So again, just generally knowing what class these drugs fall into and why we generally don't use them. We don't want to be, mainly it's the tachycardia that we're concerned about. And then of course, specifically with pseudoephedrine, it's really not available here either. So that's fine. We'll just leave that at that. Okay, so now this is a class that we definitely use. So bronchodilator drugs. Bronchoconstriction, nice little term there, of course we know is the contraction of smooth muscles surrounding the small terminal bronchioles. So bronchoconstriction means that the animal's going to have challenges with their breathing, right? They could be dyspneic. This in general is all related to the parasympathetic receptor stimulation, and we have involvement of muscarinic choline receptors, acetylcholine, or mimics of acetylcholine. All of these are going to get stimulated and cause a parasympathetic response to cause bronchoconstriction. And like I mentioned a second ago, bronchoconstriction is going to create difficulties with breathing. So very common diseases that involve bronchoconstriction are feline asthma, equine heaves /RAO. They're calling it RAO, recurrent airway obstruction now. They've switched it. So those are the two most common, and feline asthma is very common. We talked about feline asthma when we talked about anti-inflammatory drugs, because quite often we're treating that disease with bronchodilator drugs along with steroids as well to help reduce the inflammation. And just a little side note about feline asthma, very similar to children with asthma. If you smoke in your house and your cat is getting secondhand smoke, their chances of getting feline asthma, their risk increases exponentially. So if you smoke and you own a cat, please smoke outside. That's my public service announcement for the day. And this is just a little video looking at airways with asthma, which I'm kind of concerned that it won't, pardon my cat here, I gotta move him, that it won't play on your speakers, but I can awkwardly talk over it. Let me just find the area that I would like. So essentially what this video is doing is it's showing that within the bronchioles and within the airway tract, the respiratory tract, there are little bands of smooth muscle all throughout the respiratory tract. And what ends up happening, of course, is that, air comes in, air goes out through these little openings within the respiratory tract. But when an animal has something that triggers bronchoconstriction, which it's going to depend if the animal is asthmatic, if they have allergies, any of these things can affect that triggering of the parasympathetic nervous system. Any of those triggers will cause bronchoconstriction, and then essentially you're getting a constriction of those little tiny muscles, those tiny little bands of smooth muscles, which I'll see if we can get to that point here. And we're getting a narrowing of the airway. So essentially when we get bronchoconstriction, which is stimulated, might be by, by external factors or otherwise, or it's a disease that the animal has, such as asthma, then we're getting a constriction of those tiny little smooth muscles of the airways. And then that, of course, narrows the airways themselves and can increase in mucus production. So different reasons that we get bronchoconstriction in animals. We've got inflammation and allergy induced, so histamine release from mast cell degranulation. We could have it as a result of organophosphate toxicity. So insecticides, they block the acetylcholinesterase, which means that acetylcholine has a prolonged effect on those little tiny smooth muscles and causes constant constriction. And then inhibiting sympathetic response, blocking of the beta-2 receptors, the acetylcholine antagonist properties are blocked. So that allows for bronchoconstriction. Oops. And then this, my image is terrible. I meant to fix this, my apologies. Just a little bit to think about beta-1 versus beta-2 stimulation. Just a little reminder that beta-2, you have two lungs. So if we're talking about beta-2, think lungs. Think about effects on the lungs. And beta-1, you have one heart. So anytime we're talking about stimulation of beta-1 receptors, start thinking about the heart. I just want to link that in case you hadn't already made the link at this point. Okay, so bronchodilator drugs we're going to start with beta-adrenergic agonists, and their mode of action, they stimulate the beta-2 receptors. So they stimulate a sympathetic response, and that specific sympathetic response results in a relaxation of bronchial smooth muscle, which of course is going to dilate and open up the bronchioles. And in this case too, it also is going to reduce the amount of mucus and stabilize the mast cells so that we don't get a continuation of mast cell degranulation. Examples, we have epinephrine and isoproterenol, which are both non-selective beta-1 and beta-2 bronchodilator drugs. So they're both beta-adrenergic agonists, that's quite a mouthful, but these ones in particular are non-selective. And then we move forward to the newer and more effective selective beta-2 adrenergic agonists. So the new bronchodilator drugs, so again, flipping back, epinephrine and isoproterenol. Oh boy, those two are the old ones. And then now we get into the newer ones. So these ones are specific to beta-2. So we're not just going to agonize both beta-1 and beta-2 receptors. We're specifically looking at an agonist for beta-2. So these ones, the newer bronchodilator drugs, we have terbutaline, albuterol, salbutamol, and Ventolin are examples of albuterol, and then metoprolol as well. These drugs, depending on the drug specifically, they come in tablets or a metered dose inhaler. So what you see on the right there, the Ventolin, that's a metered dose inhaler. And each time you push the inhaler, it's going to give you a certain number of micrograms of the drug itself. When we get the beta-2 stimulation, we're getting a relaxation of the bronchiolar smooth muscle. So again, it's allowing less mucus production because those airways are open and we're getting stabilization of mast cells. And they are more selective and have fewer, but still some beta-1 side effects. So just a little refresher on that one. So beta-2 side effects, we're looking at the bronchodilation, that's the goal here. But you can get a little bit of beta-1 side effects. So quite often the most common one in these cases, and same with the non-selective drugs, but the most common side effect is a bit of tachycardia. So you can get some transient tachycardia with these drugs. So just something to keep in mind. People get it too, and I'm pretty sure I talked about this previously, but if you're using a metered dose inhaler such as salbutamol or Ventolin, then you can get a little bit of tachycardia as well, which goes away quite quickly. So they tend to be safer than the old ones. Okay, so carrying on with this class of selective beta-2 agonist drugs, we've got terbutaline, albuterol, metoprolol, and clenbuterol. So all of these are different options depending on the species and what we're using them for. Dogs, cats, and horses generally are what we're using them for. Very, very common that we're using clenbuterol, which is ventipulmin for horses. The terbutaline injection is for an emergency treatment of asthma, so it's not very commonly used otherwise. And then, as I mentioned, there's a transient tachycardia that can occur with all of these. Again, it's a tachycardia that happens immediately right after the administration, then it disappears. And we potentially can get receptor downregulation as well, so that the dose has less effect with subsequent use. So the downregulation over time, less, where am I going with that? Less receptors on the cells make the cells less receptive and less sensitive to the drug over time. And then here are some beautiful examples of metered dose inhalers. So very common, your two most common patients that will get a metered dose inhaler are cats once feline asthma is diagnosed, and horses with recurrent airway obstruction or recurrent obstructive airway disease. And they're the cutest little things when you have to give them a sad little metered dose inhaler. Okay, so then we're going to move on to methylxanthine bronchodilators. And so these ones we'll talk about specifically the drugs that we use for animals. So within this class, we have theophylline and aminophylline, which are two drugs that we use regularly in clinical practice. I just want to point out as well that caffeine and theobromine are also part of this class of drugs. So caffeine, so we're talking about coffee, and then of course chocolate, they have those CNS stimulant agents within them that technically cause bronchodilation as well. Salt. Aminophylline is, when broken down in the body, it is 80% theophylline and 20% ethylene salt. And with that, the salt facilitates absorption of the aminophylline and allows the drug to better be tolerated by the GI tract, if that makes sense. So aminophylline is converted to theophylline after ingestion. What we're generally using this for, aminophylline in feline asthma cases and in canine congestive heart failure and bronchitis, we might be using them as well. So carrying on with this, of course, there's going to be some downsides. So the drug theophylline, which is often as a slow-release drug, can cause nausea and diarrhea in dogs. In general, there's a narrow therapeutic index for muscle spasms, tremors, etc., due to its central nervous system stimulation. So we have to watch out for that as well. It does cause a transient tachycardia. And theophylline has multiple drug interactions. So it interacts with anticonvulsants, with clindamycin, and cimetidine as well. In general, it has a narrow safety margin in horses with recurrent airway obstruction as well. So it's one of those drugs that it's used if needed, but ideally we try to avoid it because of all of its unfortunate side effects. But the one that you will see, just flipping back, is aminophylline. That's the one that we will use in long-term cases of feline asthma, especially when they're not regularly controlled very well by the metered dose inhaler. And then the list goes on. When we're talking about respiratory drugs, like this list is massive because of so many things that can stimulate the respiratory tract to have issues. There's going to be an array of drugs that would be beneficial for the respiratory tract. So it depends on the diagnosis and the clinical signs of the animal. So we've got steroids for inflammatory diseases and autoimmune disorders. We have antimicrobials for bacterial pneumonia and upper respiratory infection. We have antivirals, we have antiparasitics, antihistamines, and diuretics if it's pulmonary edema that's causing the coughing. So lots of potential drugs for use there. And then, of course, super, super important, anytime a patient comes to your clinic and they're demonstrating dyspnea, so they are having issues with their breathing, you, as the RVT, the first thing you need to do is get them on the exam table or whatever, wherever they are most comfortable, and start assessing them while they have flow-by oxygen in front of them, because we cannot forget the importance of oxygen for these patients. Regardless of what's causing the respiratory tract disease, if they can't breathe, they need more oxygen. So these are all different mechanisms through which we can give oxygen. We have a direct hose connected to an oxygen tank for the cat. We have a nasotube that's given to the dog for, that's of course connected to a tank as well. We have sort of an e-collar aero chamber here that they've created using saran wrap, obviously not done up all the way, but about 3/4 of the way. We have an at-home oxygen tank created by saran wrap over a kennel with an oxygen tank. And then, of course, we have the humidified oxygen in a true oxygen chamber. And that is the end.